Greetings, my name is Gan Wei Ni and I'll be presenting my research titled Legal Framework on Affordability and Quality of Healthcare in Malaysia and France. Let's begin. As you can see, this chart shows that Malaysia's budget 2020 allocations to healthcare increased 6.7% from 28.7 billion ringgit to 30.6 billion ringgit. Hence, strongly indicating Malaysian government's continued belief in the importance of expenditure on healthcare. Nevertheless, the dichotomous healthcare system poses imbalances and discrepancies in terms of resources and workload. With only 51% of total health expenditure, nearly 70% of all inpatients and 95% of all outpatients are treated by the public system. This tells us that either the private sector is grossly inefficient or its bills are questionable. As a matter of fact, a whopping 58% of 344 Malaysian hospitals are for profit compared to US and Singapore. Moving on to the research problem, Malaysia's medical costs showed a steady increase from 2016. It increased in 2017 from 11.8% to 12.6% and hit 13.2% in 2018. Factors contributing to the rise in medical costs are medical technology and aging population. As healthcare costs continue to rise, it is necessary for everyone to have life and medical insurance, but insurance penetration in Malaysia remains low. Based on the general population, fewer than 40% of Malaysian citizens own a life insurance or family plan. Therefore, the budget may not adequately address the need for a sustainable long-term healthcare financing solution despite the increase in healthcare allocations. Moving on, the specific key objectives are derived. 1. To define the concept of affordability and quality of healthcare. 2. To identify the legal framework of affordable healthcare industry in Malaysia. 3. To identify the legal framework of affordability and quality of healthcare in France. And 4. To provide suggestions on how to improve healthcare affordability and quality in Malaysia. Next, research significance. First, the medical industry benefits because the results of this study will provide medical professionals with strategies for being more cost-effective and efficient in delivering healthcare. This study helps patients to improve their health status at a lower cost too. Communities will enjoy a comprehensive range of affordable healthcare services. Last but not least, this study also helps to promote medical tourism by enhancing Malaysia's profile as the world's top destination for quality healthcare services of world class. Moving on, what is affordable and quality healthcare? According to Exim, affordability of healthcare defines whether a person or organization has sufficient income to pay for healthcare expenses or provide for them. Such expenses could be insurance premiums or direct healthcare service costs. According to the Joint Commission, quality is the degree to which patient care services increase the probability of desired outcomes and reduce the probability of undesired outcomes given the current state of knowledge. Institute of Medicine, Washington also states that quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Moving on, the Malaysian government funds public health services under the Ministry of Finance through the Consolidated Revenue Fund, which are taxes, while private sector sources are mainly from consumers, such as health insurance and out-of-pocket payments. The financing system is oriented towards the public sector, whereby for each outpatient visit, only a nominal 1 ringgit fee is charged in compliance with the Fees Medical Order 1976. Now let's look at why the World Health Organization ranked France the best national healthcare system in the world in the 2000 report. First of all, France's health ministry sets and implements government policy in the healthcare system structure and financing within the framework of the Public Health Act. Second, all residents are automatically enrolled with an insurance fund financed by various kinds of taxes and state subsidies. Moving on, in Malaysia, the Private Healthcare Facilitation and Services Regulation 2006 established the basis for licensing and controlling private hospitals and healthcare facilities. The government uses privatization as a policy tool to reduce the public sector's financial burden. Meanwhile, healthcare is an increasingly privatized sector in France. Now we are looking at the expansion of two healthcare schemes, MySalam and PKB40. MySalam scheme provides takaful coverage in the event of a critical illness and hospitalization. The scheme will be expanded to cover 45 illnesses instead of the existing 36, those aged up to 65 years old compared to the current 55 years old, and those with gross annual income up to 100,000 ringgit. PKB40 scheme provides checkups and early intervention for non-infectious diseases to those aged between 50 and 60 years old, will be expanded to those aged 40 and onwards. Next, health insurance is optional in Malaysia, but plans for setting up a national health insurance scheme dates back to the midterm review of the 4th Malaysian Plan and later again in the 7th Malaysian Plan. On the other hand, the French government has been progressively involved in controlling health expenditures funded by statutory health insurance over the past 2 decades. SHI is universally granted under the PUMA, Protection Universal Melody or Universal Health Coverage Law starting January 2016. Citizens can opt out of SHI only in rare cases. Moving on to methodology, qualitative research method is used to identify the legal framework of affordability and quality of healthcare in Malaysia and France. Exploratory research design is applied to explore how affordable is healthcare in Malaysia and France, and also to look into the extent the laws that are actually governing healthcare affordability and quality in both countries. The target population is medical professionals and lecturers in Malaysia. The sampling location is at Utah Sungai Long, Management and Science University, Pantai Hospital, and Polyclinic Pertama. The sample size is 5. Data collection methods are via primary data from interviews and secondary data from journals, newspapers, books, and other credible online sources. The research instrument used is semi-structured face-to-face interviews. Next, 6 steps for thematic analysis in data processing was followed. The first step is familiarization. Step 2, coding. Step 3, generating teams. Step 4, reviewing teams. Step 5, defining and naming teams. And step 6, writing up. As you can see, 10 teams were generated for data analysis. Moving on to findings. The findings for Team 1, definition of affordability and quality healthcare. A two-tiered system where public hospital provides a very low nominal fee and private hospital that charges patient for profit. In terms of quality healthcare, both do not compromise in its treatment. The only difference is in terms of external services. Public hospital will have large masses to treat and therefore not enough hospital beds, shortage in equipment, and long waiting time to see doctor. Private hospital will cater to those who can afford the high charges, but normally with insurance coverage. It has less waiting time to get treatment, more comfortable, and it will not overflow with patients occupying the hospital beds. The findings for Team 2, impact of privatization towards healthcare affordability and quality. Private healthcare's main objective is to make profit. it is more expensive and need insurance coverage, the willingness to pay for external factors such as shorter waiting time, better furniture and equipment, etc., increase the cost of healthcare. However, this does not necessarily mean that its treatment is on par or better than public healthcare. The patients are mainly given a choice to seek comfortable and external quality services if they have the money and insurance coverage. In general, healthcare quality is increased as private healthcare takes financial and work burden away from public healthcare. The findings for Team 3: Potential risk of out-of-pocket healthcare spending. Out-of-pocket healthcare spending can easily be more than what the patient can afford. The patient only knows the total bill after the treatment. This unpredictable cost may result in credit card debt and, worst scenario, bankruptcy. The patient may end up in poverty and have less savings or retirement fund for old age. Private hospitals may discontinue treatment if the patient is unable to pay the cost, and this increases the morbidity and mortality of the patient. The findings for Team 4: Potential benefit of National Health Insurance Scheme. A National Health Insurance Scheme ensures that all citizens have insurance coverage. It benefits citizens as the cost of healthcare is spread among tax-paying citizens. The out-of-pocket healthcare expenditure risk is reduced, and it serves as a financial protection during health emergency. Nonetheless, this scheme is more beneficial to the B40 group because they may seek treatment without any worry. The findings for Team 5: Potential challenge of implementing National Health Insurance Scheme. Future needs and future costs in the implementation must be carefully considered. More tax to be imposed and become burdensome to taxpayers. The government would be burdened with an extremely heavy cost. Census to document every citizen would take months to years to finalize the list to implement the scheme. Private healthcare might take advantage of the scheme, and healthcare would become more expensive. Additionally, implementation may be difficult for those with low income, without stable income, and without proper healthcare access. The findings for Team 6: Malaysians' awareness about PKB40 and My Salam. Most of the respondents only became aware about PKB40 and My Salam upon being asked. Most of them described PKB40 as an incentive to help eligible recipients, in particular the B40 group, to get early checkups for NCDs, whereas My Salam is like a health insurance mainly for B40 citizens. They can claim money from the government over days spent hospitalized, which allows them to concentrate on recovery, as they will be refunded with cash for the unpaid medical leaves taken. The findings for Team 7: Suggestion to improve the uptake and support of PKB40 and My Salam. PKB40 and My Salam cover only minimal amount of healthcare costs. Therefore, quantum of coverage should be increased to get more support from private GPs. Besides that, private GPs, general practitioners, can be given monetary or service incentives whenever they treat the B40. To increase the uptake, the government can increase awareness through legislation and education. Further suggestions are easy access to sign up for the schemes, roadshows, advertisement on television, pamphlets distribution, talks, and free health screening to the B40 group. The findings for Team 8: Law enforcement of healthcare in Malaysia. Most of the respondents mentioned Private Healthcare Facilitation and Services Regulation 2006. Other than that is the Medical Act 1971. These laws govern the qualifications and continuous qualification of medical practitioners. None of the respondents know of any laws that regulate healthcare affordability in Malaysia. The findings for Team 9: Lessons from France, Affordable and Quality Healthcare. There are many similarities between France and Malaysia's healthcare system. The difference is, all the citizens in France have national health insurance, and private healthcare providers there do not simply put prices just to make profit, whereas Malaysia has affordable public healthcare, but private healthcare is expensive and mainly for those like the T20 group who can afford health insurance. If Malaysia implements the National Health Insurance Scheme, the B40 and M40 group would have sufficient amount to cover treatment costs when they choose private healthcare and get higher quality care. The findings for Team 10: Recommendation to improve Malaysia's healthcare affordability and quality. First, awareness may close the gap on responsibilities and duties among citizens, private healthcare providers, and the government. Second, discontinue the two-tiered healthcare system and implement national health insurance scheme funded by taxpayers according to their tax bracket and government subsidies fairly distributed to all citizens. Third, focus more on preventive healthcare by educating the citizens. This helps government to save costs, which leads to more funds for public hospitals in the long run. Fourth, provide better incentives to retain good doctors. Fifth, have more well-trained staff and give importance to infection control. We have finally come to the final chapter, implications of study. This research shows that Malaysians will benefit greatly from the National Health Insurance Scheme, especially the low-income and middle-income groups. Besides that, its implementation challenges and funds healthcare system may serve as references for policymakers to draft strategies on how to effectively implement the National Health Insurance Scheme in Malaysia. Based on the findings, more actions need to be taken to raise Malaysians' awareness about PKB40 and My Salam. They are important schemes to achieve better healthcare affordability and quality in Malaysia. The government must continue to invest in these schemes to ensure success. Therefore, this research provides useful suggestions to improve the uptake by citizens and support from private general practitioners. It is evident that healthcare quality in Malaysia is well regulated, but many people are not aware that professional fees such as consultation fees and procedure fees in private hospitals are strictly regulated by the Ministry of Health. However, fees other than the professional fees are not regulated. Our beloved Health DG of Malaysia states that the government does not regulate the affordability of medicines and hospital fees such as fees for accommodation, laboratory investigations, use of equipment and operation room, nursing care, and etc. This explains why the total cost of medical treatment in a private hospital is more expensive compared with the total cost incurred in a public hospital, which is highly subsidized by the government. Moving on to limitations and recommendations. The three limitations of this study are limited time, small sample size, and no statistical representation. Following this, the first recommendation for future research is to conduct an email interview or online interview rather than meeting in person. This speeds up the data collection process. Second, increase sample size by conducting focus group interviews, which involves larger number of participants. Third, use quantitative research method, as data gathered will yield more significant and reliable results. That is all from me. Any questions, please leave them down in the comments below. Thank you.